Step 1. Ensure the scene is safe. Then, firmly tap the person's shoulder and shout loudly, "Are you okay?" to check for responsiveness. This is step 2. If there is no response, point to a specific person, tell them to call emergency services and get an AED immediately. Step 3. Lean over the person and check for breathing. Look at their chest to see if it rises and falls for about 10 seconds. Step 4. Begin compressions. Place the heel of one hand in the center of their chest, put your other hand on top and interlace your fingers. Step 5. Push hard and fast. Compress at least 2 inches deep at a rate of 100 to 120 beats per minute. Do not stop. Continue performing chest compressions until professional medical help arrives and takes over, or until an AED is ready to use.
When a person collapses and their blood flow stops, the clock on their brain starts ticking immediately. Within 4 to 6 minutes of oxygen deprivation, neural pathways begin to darken and brain cells start to die. To understand how to intervene, we have to distinguish between 2 completely different biological emergencies. A standard heart attack is a plumbing problem. A sudden cardiac arrest is an electrical failure. In a heart attack, cholesterol or blood clots block a coronary artery. The heart is still pumping, but the muscle below that specific blockage is starved of oxygen and begins to die. Sudden cardiac arrest is different. Here, the heart's internal pacemaker, the SA node, malfunctions. The orderly electrical signals turn into chaotic, irregular impulses, called ventricular fibrillation. The heart completely loses its ability to pump blood to the rest of the body. This chart maps the raw mathematical reality of that electrical failure. Yet, when an untrained casualty witnesses a sudden collapse, the most common response is to freeze. The first barrier is a fear of liability and harm. Bystanders worry that if they apply pressure to a fragile chest, they might break ribs or perform the technique incorrectly, making the situation worse. The second, and often more powerful barrier, is the fear of disease transmission. Traditional CPR requires mouth-to-mouth rescue breaths, forcing a stranger to share bodily fluids with the victim. This forces a practical medical question. Is mouth-to-mouth ventilation strictly required to save a life, or is there a valid, simplified alternative that bystanders are actually willing to perform? Doing nothing guarantees a 0% chance of survival. Hesitation kills exponentially more people than imperfect technique. We need a method that removes the psychological friction. That method is hands-only CPR. It eliminates the rescue breaths entirely, relying exclusively on continuous deep chest compressions. The chest acts as a manual pump. Pushing down hard and fast on the center of the breastbone physically squeezes the heart against the spine. This mechanical pressure forces trapped blood out of the chambers, pushing it into the brain. But pumping blood is useless if it doesn't contain oxygen. The biological loophole making hands-only CPR viable is residual oxygen. Humans breathe air containing roughly 21% oxygen, extracting only a quarter of it. At collapse, the bloodstream still holds approximately 16% oxygen. The trade-off is time. You are circulating a finite supply. Once that residual 16% is fully depleted, the compressions are just moving deoxygenated blood, and the brain begins to starve again. Hands-only CPR trades long-term patient viability for absolute simplicity. It sacrifices sustained oxygen levels to guarantee that an intimidated bystander will actually take action in the first critical minutes. Conventional CPR is the traditional approach taught to medical professionals. It pairs regular chest compressions with active mouth-to-mouth rescue breaths. Those rescue breaths solve the residual oxygen problem. By exhaling into the victim, the rescuer forces a fresh 21% concentration of oxygen back into the lungs, pushing it across the alveoli and directly into the capillary network to refuel the blood. The cost of this sustained oxygenation is complexity. It reintroduces the risk of infection, and properly alternating between compressions and breaths requires formal training and muscle memory. This comparison matrix clearly illustrates the split. We weigh hands-only against conventional CPR across skill, risk, and time. Hands-only clearly wins on minimal skill and zero infection risk. Conventional CPR is the only method winning on sustained oxygenation. But there is a physical technology that alters the math for both methods: automated external defibrillators, or AEDs. A chest compression can buy time, but an AED can actually reset the electrical chaos of ventricular fibrillation. Community alert apps like SCDF My Responder can instantly notify nearby citizens of a cardiac arrest and pinpoint the closest AED within a 400-meter radius. While conventional CPR is clinically superior for long-duration events, pairing immediate hands-only CPR with rapid access to an AED often yields the highest practical survival rates. Because of these trade-offs, the best CPR method is entirely contextual. It depends on your level of training and the specific reason the casualty collapsed. This decision tree provides a standard protocol to evaluate a collapse in real time. It starts right here, the moment the person becomes unresponsive. The very first diagnostic question you must answer is about yourself. Are you formally trained and comfortable stepping in? If the answer is no, if you are untrained, out of practice, or hesitant to perform mouth-to-mouth, you take the left path. You immediately default to hands-only CPR. Pumping the chest keeps residual oxygen flowing to the brain. Even if that oxygen drops over time, this physical action is mathematically superior to standing still and waiting for paramedics. But if your answer is yes, you are trained and comfortable, you face a second critical diagnostic question. What caused the arrest? If you are dealing with a drowning or a choking victim, this is a respiratory arrest. Conventional CPR with rescue breaths is strictly required here. The biology dictates this. In a drowning, the casualty's lungs and bloodstream have zero residual oxygen left to circulate. Compressions alone will accomplish nothing. You must physically force air back into the system. Finally, if you are a trained responder dealing with a standard cardiac arrest, conventional CPR remains the clinical gold standard. Supplying fresh oxygen while compressing the chest offers the highest probability of preserving long-term brain function. Taking a formal certification course gives you the tools to be a prepared citizen. You learn the precise ratios, and you learn to carry a pocket mask to eliminate the infection risk of rescue breaths. Pairing that training with responder apps puts you on the grid, ready to complete the chain of survival the moment someone's biological clock starts ticking down. Remember, perfection is the enemy of survival. Whether you are providing simplified compressions to buy a few precious minutes, or applying advanced techniques to fully oxygenate the blood, taking immediate action is the only choice that matters.